Today, we're going to continue the series I've been doing on the missing perspective, meaning the patients that started their transition socially as children. And we talked about when and how it goes, and then the medical transition for those that choose the medical transition, when and what that looks like. And so today, we're going to talk about the surgical transition, when and what it looks like. Now, for many people that are very supportive of the community and supportive of transition, this is an area that many times creates hesitation, or sometimes this is an area where people may feel like this is where I draw the line and I don't support it. And so, if that is you, you really want to hear this episode because I think you're going to be pleasantly surprised at what you are going to learn. You want to know this information because by the end of this episode, you are going to see the value in supporting, when appropriate, gender affirming care at those younger ages. So, what we're going to talk about today, before I get too far ahead of myself, is what is gender affirming care, surgically speaking? What qualifies as that? Then we're going to talk about who gets gender affirming surgery. And we're going to talk about what that looks for those that transition beginning in childhood. What does it look like in their later adolescence and adulthood? And finally, we'll discuss some of the implications of that societally, as well as why I think this is the reason that more people should support gender affirming care when it is needed and not taking a watch and wait approach. Okay. So, what is surgical gender affirming care? What qualifies for gender affirming care surgically? So, it can be things like top surgery, whether that's breast augmentation or breast tissue removal. That can be bottom surgery. So, exactly that, phalloplasty or vaginoplasty, things like that. It can be an orchiectomy. It can be a total abdominal hysterectomy, bilateral salpingo oophorectomy. What I'm talking about there is removing the gonads, removing organs. It can be voice surgery for those that may have a deeper voice and want to have a higher pitch voice or a more feminized voice. There is facial surgery, facial feminization surgery, or facial masculinization surgery. There are invasive things that may be considered less surgical, but still in the category, like electrolysis for facial hair. All these things are gender affirming surgeries. So, who gets them? When we're talking about under the age of 18, we're talking about minors. Most of the ones I've mentioned are not done. Out of all those things offered, what typically might be done is top surgery. And that is the removal of breast tissue, not typically breast augmentation, but that might be done, especially in cisgender individuals, potentially transgender individuals, not insurance covered, but paid out of pocket in both of those categories. But let's look at who's getting that. So this is really interesting to discuss because last June in JAMA, there was an article that was published that looked at who is getting gender affirming surgery. So there's a lot of discussions that maybe too many youth are getting gender affirming surgeries. And so they looked at an insurance database. So it had to be surgeries that would be covered by insurance. That's why I think breast augmentation would be hard to do this research, because most people, whether they're cisgender or transgender, that might get breast augmentation would probably have to pay out of pocket. But what they looked at is a registry based on insurance, and they looked at adults and youth. And so I'm going to focus, because what we're talking about is those under the age of 18. So out of those under the age of 18, all gender identities, they looked at 22,827,194 individual charts. And when they looked at those that had the diagnosis of transgender or gender diverse identities, they looked at how many people had gender affirming surgeries. So out of adults, 5.3 per 100,000 patients had gender-affirming surgery, so about 0.5%. 5.3 out of 100,000 adults had gender-affirming surgery. When they looked at minors that were between the ages of 15 and 17, so 2.1 per 100,000 patients that were 15 to 17 years old had gender-affirming surgery. When they looked at the ages of 13 to 14, 0.1 per 100,000 patients had gender-affirming surgery. I'm going to say that again. 0.1, this is not a percentage, 0.1 per 100,000 patients. So that would basically mean you would need 1 million patients that were 13 to 14 years old to find one that had gender-affirming surgery. And out of those patients that were 12 and younger, any guesses? 0. There were 0 surgeries for 12 and younger. So the numbers here are very low at looking at those that received gender-affirming surgery at all. Now, that when they did a comparison to cisgender patients, they specifically looked at breast reduction. Why is that? Because breast reduction in cisgender male patients is considered a gender-affirming surgery. To remove breast tissue in cisgender males is a gender-affirming surgery. The other thing is that insurance will typically pay for that surgery, and they will pay for it in minors. So that is something that would be discoverable in this data set, and we can compare it. So when they looked at chest surgeries in this group, breast reductions in particular, in minors, so looking at those under the age of 18, of all of them that were done, 97% of breast reduction surgeries were done on cisgender patients. I'm going to say that again. 97% of the breast reduction surgeries done on those patients who were under the age of 18 were cisgender. 3% of those surgeries were done on transgender or gender diverse patients. That means the majority of gender-affirming surgery in this study was done on cisgender patients. Okay. So I think that is important to remember. And it's not surprising. It's not surprising because of the level of scrutiny that for every aspect of medical care that transgender and gender diverse, meaning non-binary, patients undergo for every aspect of their care is heavily scrutinized. I remember one time attending a talk done by a plastic surgeon given to a room full of adults. It was adults who were transgender, non-binary, gender diverse identities. And he was talking about the top surgeries that he did and demonstrating and explaining the different techniques and everything. And at the end of his talk, after explaining what he did, somebody in the audience raised their hand and said, "What kind of notes do you require? Letters of support do you require?" And he was confused. He said, What do you mean? What kind of letters of support do I require?" They asked, "Well, like, do you require a therapist note? And if so, how long do we have to have seen the therapist, or how many visits, or like, what is the requirement in order for us to be able to have top surgery with you?" And he looked confused. And mind you, this was probably about 10 years ago or so. He said, "I don't require that. I don't require that out of my cisgender patients that get breast reductions or breast augmentation. I assume as adults, when we have a conversation, that I feel they're in sound mind and they know the decisions they're making, and that's good enough. Why would you be any different?" Even though that physician realized that. That is not the way gender-affirming care for transgender and gender diverse patients has been treated. Whether that's right or wrong, that is the truth. It is under more scrutiny, so it is not surprising that there is way less in that group. Now, when we look at the patients that I've been talking about that start their transition socially and then medically begin their transition, for those that decide to have a medical transition, when they start that medical transition after puberty has begun, peripubertal medical transition, the interesting thing about these patients is that they rarely require top surgery. Definitely for the trans masculine individuals, don't require top surgery. They don't develop breast tissue. Assuming that puberty blockers are started at Tanner stage 2, there's no top surgery required. For trans feminine, they're like a cisgender individual. It depends if they are satisfied with the size of their breasts. They might want breast augmentation, but that doesn't necessarily have to do with the failure of the medical treatment. I would offer that more has to do with societal's impact, but that's a story for another day. So top surgery is less necessary or not at all. And then facial feminization and facial masculinization is not necessary as adults. Now, those aren't things offered to minors, but as adults, they're not going to require those surgeries. If they transition and they have medical transition, peripubertal, they're not going to require electrolysis if they transition peripubertally. The only thing they may decide, depending on them, is bottom surgery. Most bottom surgery, especially the trans masculine bottom surgery, is done after the age of 18. For trans feminine bottom surgery, most are done after the age of 18. The exception to that is that sometimes the summer after someone graduates high school, if they are not 18 yet in that summer, usually they're close to it, some people may do surgery in that summer. Why? Because it is an opportunity to have the surgery and recover at home when they have assistance, when it's not going to interrupt their studies. It's a good pause period if that is something the patient desires between finishing high school and if they decide to go on to higher education before starting that higher education. So that is really the only exception that might be done is bottom surgery in the trans feminine patients that desire it. And let's remember that not every patient desires bottom surgery. Some people don't desire bottom surgery at all. But for those that do, that might be the exception to doing a surgery prior to the age of 18 in these groups. But for the most part, those that transition prior to puberty don't require surgery, rarely ever before the age of 18, and hardly ever at all in their lifetime. That's one of the benefits. So if we actually think about the laws being placed, because there's concern of what we're doing to bodies and that maybe there's, quote, too much, let's think about what we know now. We know that most surgeries are done on cisgender patients, in which case those laws are probably going to impact cisgender patients more than anyone. Now, some of you may say, no, but if we write the law specifically to say for transgender or for gender dysphoria, it won't affect them. And I'm going to tell you that that's not the case. We've seen it over and over again in medicine when somebody makes a law, even if it's for a specific diagnosis. It affects when that treatment is used for something else, even if it's a different diagnosis. I'll give you an example. I heard testimony of a young woman in Florida where medical gender-affirming care was made illegal. She was not transgender. She received hormone replacement therapy because she had had a gynecologic cancer and had had her ovaries removed and her uterus removed, and so required estrogen for her life, for her health, and she couldn't get it filled because there was concern that it was gender-affirming care. So that was a completely different diagnosis. She needed hormone replacement therapy because she didn't have any and she was early 30s. The point is that even if you think things are protected because it's for a different diagnosis, what happens in reality is when a treatment is the same, even if it's for a different diagnosis, patients tend to be affected, even if it's for a different diagnosis. So yes, I do think patients will be affected. Cisgender patients will be affected. The other thing to consider is that when we support patients, instead of taking a watch and wait till they're over 18, we decrease the number of surgeries that they will need. When appropriately applying gender affirming care to those who are transgender, we actually decrease the chance they need surgery, therefore decreasing their risk of morbidity and mortality related to surgery. There are so many other benefits, as I've mentioned in the past episodes, but this is a big benefit. You decrease the need for multiple types of surgeries. So when we talk about providing gender affirming care, this is part of the conversation, especially for those that transition prior to puberty, supporting those social transitions for those kids that are elementary school age, meaning using the name they use, using the pronouns they want to use, allowing them to dress they want the way that aligns with who they are, allowing their hair to be the way they want their hair to be. There is no harm in that. But then furthermore, as they develop, supporting them through that medical transition, allowing that pause. And then if they so desire it, allowing, and as a team, remember, everything's a team decision. The team deems that they are appropriate candidate and they, as the patient, desire that medical transition. And doing that has so many benefits, including making it less likely that they will ever need a surgical transition. Because supporting gender affirming care matters.